Hello, everybody, and thank you so much, Molly, and to the whole team at TPHC for, first of all, their support throughout the building of this project and also planning this webinar, which is really wonderful to see all the different projects in London come together. I'm going to talk to you very specifically about our project, which admittedly is in its infancy, dealing with social welfare and cardiovascular disease. And I think from our point of view, there are two major hurdles to implementing social prescribing in a secondary care setting. The first is awareness about social welfare and the impact on cardiovascular risk. And then the second is integrating into that network that's already so rich and beautifully robust throughout primary care, where secondary care really didn't have a role before. And so I think to address the first one, it's really clear there's a ton of pretty gold standard evidence that shows that the risk of being socially deprived is equivalent almost to the risk of high alcohol or hypertension in terms of the impact on cardiovascular mortality. It is a no-brainer that us at the Heart Hospital should be dealing with social welfare and social deprivation in our regular and just routine care for patients. But it became pretty apparent to me when I started integrating this question into my practice. And I'm a vascular surgeon. When I deal with aneurysm disease, which is the bulk of my practice, I occasionally ask patients, do you have difficulty making ends meet at the end of the month? And I have been very surprised at the impact that the answer has on people's decision-making for whether or not they want surgery and how compliant they are with their care. In fact, with this specific patient who had a symptomatic aneurysm that needed treatment, I connected him with a social prescriber when he admitted to having financial issues. And at the end of the surgery, everything went really well. And he really credited the social prescriber for saving his life because it was the social issues that were causing the biggest burden in his day-to-day stress and well-being. We decided to kind of start on this journey doing a fact-finding mission. So the first thing we did was deploy a question across anyone who engaged with our app and ask them, do you have difficulty making ends meet? And what we saw here is that there was a significant portion of patients with aortic or cardiovascular disease who really had difficulty at the end of the month. And we thought this was a big enough fraction of our population that we should explore it further. And so we brought the same question to the outpatient cardiology clinic in Newham. And using the digital questionnaire, we actually this time developed a screening tool where we asked a number of different questions of the patients that were coming to outpatient clinic. And we screened about 150 people in the process of this project last autumn. And what we found, not surprisingly, that digital engagement was quite low amongst this group. And but for those who did complete the questionnaire, there were quite a bit of concerns, and specifically financial deprivation became really apparent. And the lessons we learned from this was that there definitely is something needed and something we can provide in this space, but it needs to be done with a human being. And so we worked with public health, and one of the first things we did was bring a health and well-being coach into the renal disease department. And the public health department at Barts is absolutely brilliant. And what we found, and Maisha has been in post since August, she was able to engage with every new dialysis starter, and they were completing the questionnaire 80% of the time and flagging a concern quite frequently. And so this says to us that having a human being involved is really important, which is where we are now with the Barts Heart Pathway. What we've decided to do is screen everyone who has an acute MI, and that's 5,000 heart interventions done a year at Barts, using our digital questionnaire. But for those who can't engage with the digital questionnaire, we've embedded a social prescriber in the pathway. And our ACPs and social prescribers are screening the patients. And if they flag for concern, then they're actually getting extra social prescription, either from the social prescriber we've brought on board or by engaging with the community and dealing with their local social prescribers. Our process map looks something like this. After a person has an MI, they get screened. If they don't show up, then they're immediately flagged as a concern, and they're called by the social prescriber. And for those who are screened and flagged as a concern and who want help, then they're also flagged as a social prescriber. what we found is that this pathway is really fitting beautifully with the psychology support that we already provide along the acute MI pathway, as well as the safeguarding support. It was actually that missing piece of social welfare that was needed in this population. And what's interesting is that it's integrating into a much larger network. What we're finding is that a lot of the things that cause cardiovascular disease are also the things that are leading people to screen positive. And certainly when we push them back out into the community after their heart attack, what we're finding is that a lot of the things that cause the disease are the same things that are preventing them from being well. And so it stands to reason that we have engaged across all of Northeast London in order to integrate this pathway, learn from the brilliant teaching that the primary care network already has, and hopefully bring some of that learning to what we're doing. There is no question we are building this plane in flight. It sometimes feels like we are constantly changing what we're doing, but what our hope is that by being a reasonably nimble pathway, we can actually express and deal with the concerns that patients bring up. We've changed our tool again so that instead of asking all those questions, which became really time consuming, we're just asking one question, but really leaving it open for the patients. And the outcomes that we're looking to understand is the burden of the disease, the classification systems that we can use to understand the burden of disease, the needs in the community, and then hopefully with social provider intervention, what we're hoping is that we can also show that there are some decrease in resource utilization. And you can see that this project is very early on. We've just brought the social prescriber in, Remy, who's brilliant, in 2023, in the beginning of November, and we've just started to screen patients. And our team brilliantly has been working over Christmas and has screened almost 100 patients so far. And what we found is that almost a third of patients who are screened through this pathway are having difficulty making ends meet at the end of the month. So there is no question that this patient population is in dire need coming through the heart attack pathway, and hopefully will be something that we can help address. Hopefully by this time next year, I'll be able to tell you the huge, beautiful impact that our wonderful ACPs and that Remy has made on the care in the patients in the pathway. The goal at Barts really is to change the current social prescribing ecosystem in Northeast London so that we can integrate and really be responsible team members in taking care of our patients and their social welfare needs. And it's thanks to the beautiful, wonderful people at TPHC and everyone across Northeast London that we've been able to make it this far. And I thank you for the time.
Thanks, Tara. That was brilliant. I mean, I think it was amazing to hear more about, well, really powerful, first of all, to hear more about the link between social deprivation and cardiovascular disease risk, but also great to hear about how personalised care roles can really help to link up secondary care, primary care in the community as well. So thank you. Does anyone have any burning questions? We will have more time for questions for the presenters in the panel discussion, but we might have time for one just now, if anyone. Yeah, Rebecca.
Thanks for that. That's a really interesting perspective. I'm my Bromley lead in South East London for personalised care, and part of our mapping process we're doing at the moment is looking at how everything in personalised care really links up, and communication between the different services is key. So I'd be interested to know how the work that's being done in the clinics in that way, how is that being communicated back to primary care?
That is a brilliant question, and one of the things that we struggle with the most. We're using the East London patient care, forgive me, I'm blanking on the name, but the patient record, excuse me, the East London patient record. Much of the correspondence we have for GPs goes into that record. And so by using our common pathways for corresponding with GPs, we're able to upload it into their system so they can see. What we don't have is a case management tool that can allow us to collect coding and really understand social prescribing the same way that the primary care network does. However, we've built a very, very basic database collecting those same same codes. And what we're hoping is that when we have the evidence that this has been effective, the commissioning or the funding for this will come at a bit of a higher level, so that social prescribers across the entire network will be using the same tools. But that's a bit of hope right now.
Great. Thanks, Rebecca. Thanks, Tara.